For the next 10 minutes or so, what I'd like to do is to talk about MRI patterns of shoulder denervation and try to show you how your shoulder MRI might give you a more sophisticated diagnosis than just your typical rotator cuff tear or labral tear. The outline of this talk, we're going to talk about different causes of shoulder denervation, how we go about making that diagnosis, do a little bit on the MRI appearance of nerves and muscle denervation, and also talk about specific neuropathies you may encounter in the shoulder. There are really three main causes of shoulder denervation, the first one being the most common, which is different types of entrapment neuropathies. Two other causes of shoulder denervation include trauma and a rarer condition called Parsonage-Turner Syndrome, which we'll close with. So entrapment neuropathies basically are alteration of nerve function secondary to compression from either static or dynamic forces. And typically patients will present with either pain or weakness in the upper or lower extremities. And compression can be either secondary to static forces, so lesions, something pushing on nerves, so tumors, cysts, inflammatory processes, or something that happens post-trauma, as well as dynamic causes, which is usually repetitive motion. A lot of these nerves travel through small, narrow tunnels, so any narrow, repetitive motion may compress on those nerves as well. The diagnosis of shoulder entrapment neuropathy is usually made through clinical and EMG findings. Now, there's a big role for MRI where the nerves course so deep, sometimes the EMG can't get down to actually analyze the nerves or muscles well enough. There is a role for radiographs and CAT scans where you can pick up small other findings that may lead to nerve entrapments. Here's an example of this is a lateral view of the elbow, like Dr. Vidazzi's shoulders earlier, except what's abnormal here is there's a spur coming off the distal humerus. This is an avian spur that can cause entrapment of the median nerve. So there is a role for X-ray and CAT scan. If you could pick up osteophytes like this, if patients had a prior fracture and there's a big callus formation that might be pushing on the nerve, and there are lots of different bony abnormalities and variants that can cause problems too. But ultimately what MRI and ultrasound will offer you is the only ability to really see the nerve directly. We do want to review briefly what MRI is. Look at this and forget about it. Just know MRI is very expensive and very complicated. What you guys need to know about musculoskeletal MRI, two things. If the fat on an image looks bright to you, that's a T1 image. If fluid looks bright, it's either T2 or proton density. These are the three big sequences we use in the musculoskeletal MRI. And if anything looks bright to you, if you see fluid, fluid is bad, okay? At the very least, walk away knowing the fluid is bad. So when we look at MRI, we look on nerves in MRI, we have to be reminded that nerves are these beautiful, beautiful natural structures. You have axons surrounded by Schwann cells that help, insulate the nerve impulses, surrounded by various levels of connective tissue. Okay, so you think that something this delicate and intricate would look really beautiful on an MRI. Now I'll tell you, I became a radiologist because I love looking at pretty images. Okay, and sometimes the images I look at really do remind me of some artwork that I really like to look at as well. But what do nerves look like? There you have it, dots and lines, dots and lines. But if you put those dots and lines into context, you can actually get some information out of them. Okay, so let's look at these dots a little bit more closely. Okay, this is what nerves look at on MRI. They're usually low to intermediate signal tubular structures that are surrounded by fat. And thank God for the American diet. Thank God for fat, because without the fat, we would not see these nerves on MRI. Okay. Now, when nerves become entrapped, there are some MRI signs for diseased nerves. They get bigger, they get brighter. Again, fluid is bad. So if you see fluid in the nerve, that's a bad sign. But it ultimately is very unreliable because studies have shown that patients who have lots of nervous symptoms have completely normal-looking nerves on MRI, and vice versa, patients who have really weird, strange-looking nerves have absolutely no symptoms. So ultimately, looking at nerves on MRI is only so reliable. Okay, this is an axial, fluid-sensitive sequence through the ankle. Here's your tibia, here's your fibula. And one of these little circles down here, I think it's this one here, is your posterior tibial nerve, okay? Just a dot. Here's an MRI of the knee. Two dots side by side. These and more dots up here. These are vessels, these are nerves. This is your tibial nerve, here's your peroneal nerve. Again, dots. Here's a nicer example. This is a T1 image. Remember, fat is bright. All this subcutaneous fat in this lucky person is T1 bright, okay? And this little bundle of dots down here between the muscles is the sciatic nerve. You see it really well because it's really nicely outlined by T1 bright fat. Another example, MRI of the elbow. Here's the ulnar nerve traveling in the cubital tunnel. Nice little, dark little dot. On a fluid-sensitive sequence, the nerve's a little bright. Is this abnormal? Hard to tell. Really, the literature is really lacking on this. Now, here's a very, very abnormal ulnar nerve. Also an elbow. This patient has this bright, thickened ulnar nerve, which is being compressed by this muscle, which is an anconeus epitrochlearis, an accessory muscle pushing on this nerve. In this case, it's kind of a no-brainer. Here's an MRI of the wrist. Normal, flat line here. That's your median nerve. Patient with carpal tunnel syndrome, big, thickened nerve. But like I said, this can be very unreliable, and you can see normal nerves in absolutely abnormal patients. But what is really more reliable is looking for the secondary signs of nerve problems, which is ultimately muscle denervation, okay? And these are very, very reliable and can give you a sign that something really bad is going on. And what's really nice, too, is muscle denervation follows a very specific, predictable pattern. The muscle will first become edematous, become slowly infiltrated by fat, and ultimately lose volume. Here's another axial T1 weighted image through the leg. We're going to focus on the muscles of the anterior compartment here. All the muscles in the leg look the same, a little bit of fatty infiltration, but these are normal, nice, bulky muscles. This is a patient who has a peroneal nerve problem. Early on, what do we see? A lot of edema in the muscles. Compare the anterior muscle group to the posterior group. A lot of bright stuff in. Again, fluid is bad, right? This is all edematous change in a patient with a peroneal nerve neuropathy, the early denervation of muscle. This patient went on, didn't get treatment. The muscle went on to, if you compare it to the posterior muscles, losing bulk, getting more fat. These are approaching irreversible changes. So, having gone through what the background is a little bit, we'll talk about different types of neuropathies you may encounter in the shoulder. And really there are two big categories. One is if it's isolated to one nerve or whether or not multiple nerves are involved. The two major nerves you're going to focus on in the shoulder are going to be the suprascapular nerve and the axillary nerve. And those are the two isolated peripheral neuropathies you may see. And when you see problems that involve multiple nerve groups, you want to start thinking about brachial plexus injuries and, again, this weird Parsonage-Turner Syndrome. Just to review the anatomy of the suprascapular nerve, it comes off of the brachial plexus. It involves the C5 and C6 nerve roots. It comes down, dips below what's called the suprascapular notch in the scapula, gives off a branch to your supraspinatus muscle, dives deep to the scapular spine, and gives off another branch to your infraspinatus muscle. Now note that there are two ligaments here, right? There's one superior, the suprascapular ligament, and a spinoglenoid ligament, two places where this nerve can become entrapped. Like I said, it provides motor innervation to the supraspinatus and infraspinatus muscles, and also some sensory innervation to the glenohumeral and acromioclavicular joints in the shoulder as well. Now you see these nerves really well on MRI. Here's a coronal T1 image through the shoulder. These dots here in the suprascapular notch. One of these dots is the suprascapular nerve, and the other two are vessels. Here's the axial view to the same area. You see these lines running through. Remember, lines and dots. Some of these lines are vessels, but one of these lines is the suprascapular nerve. And there's a lot of variations, so it's hard to tell which one is the nerve most of the time. If we look at an actual image through the area, I'll slow this down. If you look up in this area here, you can see the tubular nerve coming down through the scapular notch and traveling through. On the axial image, sorry about that. On the axial image, you'll see the same thing. You'll see the nerves coming up through here, over the scapula, coming down posteriorly from the suprascapular notch down into the spinoglenoid notch. Bunch of tubes and lines running through. The cause of suprascapular neuropathy, when the nerve is actually involved, are either repetitive motion, patients who have a lot of abduction, who participate in sports that involve a lot of abduction and internal rotation. You can see this in the setting of direct trauma, either scapular fractures, and sometimes patients after having trauma can get calcification of that suprascapular ligament I talked about, which will further narrow that tunnel. Iatrogenically, and unfortunately this nerve can be injured sometimes during surgery, and you want to look for mass effect too, ganglia, varices, other tumors. Here's a nice big suprascapular ganglion sitting here, probably from a superior labral tear that can push on that nerve as it passes through. Here's a larger example, a huge T2 bright. Again, bright is bad, right? Big fluid-filled cyst coming off of the superior labrum, extending to the suprascapular notch, pushing on those nerves. And we're seeing the secondary findings here. It doesn't matter if you don't see the nerves, you see the outcome. You see the supraspinatus and infraspinatus muscles bright, and the supraspinatus muscle starting to lose some bulk as well. This is the secondary neuropathy from this big ganglion pushing on the nerve. Another example of suprascapular neuropathy here, this patient presents with upper extremity weakness. We see the same findings again. Supraspinatus and infraspinatus muscles both bright, abnormal compared to the normal signal subscapularis muscle more anteriorly. These are bright edematous abnormal muscles. And what we see here, this weird vessel coursing through the exact course where we expect the suprascapular nerve to be. On the T1 image, we see this tangle of vessels that shouldn't be here. This is a varix, a small little benign tangle of vessels that was causing problems by pushing on this nerve in this patient. The other isolated neuropathy we want to talk about is axillary nerve neuropathy in the shoulder. The axillary nerve is a termination of the posterior trunk of the brachial plexus, also made up of the C5 and C6 nerve roots. Here's the brachial plexus coming down. This green branch coming off here is the axillary nerve. It has a very interesting anatomy where it courses, ducts down into the armpit and courses posterior to the humerus before leading up to innervation. It innervates three muscles, the anterior and posterior deltoids, as well as the teres minor, and it has one sensory branch for the supralateral brachiocutaneous nerve. Here we see, here's again, a coronal T1 weighted image. Fat is bright. A couple little dots here down towards the armpit, towards the axillary recess. One of these is your axillary nerve. An axial image through the same area, we see these tubes running through, just medial to the humerus here. One of these branches is going to be your axillary nerve as well. we follow on an image here, on this coronal animation, we can see the nerve coming down. It comes down from up here. You could follow it right there, and kind of in the middle of the fat there. You could follow it up approximately coming on up, coming down from the neck, down along the chest wall, through that space in the axillary recess, heading posteriorly to the humerus. Axillary neuropathies, unlike suprascapular neuropathies, are almost always from trauma. About half occur from shoulder dislocations, and actually the injury to the nerve can occur either at the time of the dislocation or during treatment, either when the shoulder is relocated or during surgery. Masses are actually a rarer cause of axillary neuropathy. Suprascapular nerve neuropathies are more often caused by masses, although there is a specific entity known as quadrilateral space syndrome, which is worth mentioning. So the quadrilateral space is an anatomic region that's been defined in the medial aspect of the shoulder. It's this little square here, and it's bound superiorly by the teres minor muscle, inferiorly by the teres major, medially by the triceps, and laterally by the humeral shaft here. And this little space here, as you can see, the axillary nerve does travel through, and it provides another area for this nerve to become entrapped. There's a coronal T1 weighted image. Again, here are the boundaries. You see the teres minor up here, the teres major here, part of the humerus, and this little band coming down here is the triceps, and this little band, this little pocket of fat and tubes, this is your quadrilateral space where the axillary nerve is traveling through. Quadrilateral space syndrome is usually due to fibrous bands that form in that space that push on the nerve. It can be seen with patients who've had fractures, extreme abduction and overhead throwing athletes. Patients who wear heavy backpacks constantly can have those. And again, unlike with the suprascapular nerve, you can rarely get tumors in this location. This is a competitive swimmer that we saw who came in with a lot of upper extremity weakness. And this is the teres minor muscle here, which is, just like we saw earlier, bright, kind of swollen, bright compared to the infraspinatus muscle above it, abnormal edematous muscle. And on the T1 image, we're starting to see bright fat in it. Again, fat brightness is bad, right? Fat is bad, edema is bad. And here's a quadrilateral space here with the nerve running through it. This is a patient, a rare example of an actual mass in the axis in the quadrilateral space. This is a big ganglion coming off of the inferior labrum, and edematous change in the teres minor muscle as a result. Now, what do you do when you encounter a picture like this? You've got a mixed picture here. You have the supraspinatus, it's edematous, the infraspinatus, it's edematous, and the teres minor, involving two different muscles, right? We've got the suprascapular nerve involved with the supraspinatus and infraspinatus, then the axillary nerve involved with the teres minor. And when you see mixed pictures like this, you want to think of either a brachial plexus injury or Parsonage-Turner Syndrome. This is an uncommon self-limiting disorder characterized by sudden onset of pain in patients who have no trauma history and no real athletic history to really explain why they're having these symptoms. The problem with this syndrome is that not only is it rare, but it also mimics multiple different problems in the shoulder, either cervical degenerative changes, rotator cuff tears, anything you might see in the shoulder. This is a great mimicker. No one really knows what causes it. There has been speculation that it might be post-infection, and about 25% of patients report having a cold really right before it happens. Has been implicated with immunization vaccines, a few autoimmune diseases, and also excessive exercise. Mostly in men, about a third can occur bilaterally. There's really no specific test here for this syndrome. Your imaging and EMG findings are not going to be really helpful, and you have to really look at them with a background in the clinical history. MRI will show you exactly what we talked about earlier, is denervation-related changes in multiple different muscle groups, not explained by any one nerve distribution. And as long as you don't have a history but and you don't see any other cause of shoulder pain, is one diagnosis you're going to think about. Again, early MRI findings, what we talked about, early edema followed by fat and loss of bulk. And these findings can be reversible, but if they last more than a year, they tend to stick around. Almost all of them involve the suprascapular nerve, and about half of Parsonage-Turner cases will also involve the axillary nerve. Most patients will recover, and if they recover, it'll be early. If they stick around longer, they're usually not going to recover. Here's another example. Here's a patient presenting with upper extremity weakness, mixed pattern. We have edema in the infraspinatus, edema in the supraspinatus, and also here, edema in the deltoid muscle. So when you see mixed pictures like this, you want to think about Parsonage-Turner syndrome. So just in concluding, you should know that MRI can be a really helpful adjunct in diagnosis of neuropathies in the body, especially in the shoulder. These are really the three big types you're going to see. If you see isolated supraspinatus and or infraspinatus problems, think of the suprascapular nerve. Teres minor and deltoid, think of the axillary nerve. And if you have a mixed picture, think about brachial plexus injuries or Parsonage-Turner syndrome. Thank you.